Dr. Benjamin Iffland is with us today. I'm going to ask him to get going. He's joining us today from Bielefeld University to talk about the use of narrative exposure therapy to help people who've experienced traumatic events. Narrative exposure therapy is an evidence-based method of treatment which has been shown to be helpful in reducing symptoms related to PTSD. It's often used in a group setting and has been particularly successful in supporting people who have experienced multiple traumatic events. Dr. Iffland.
Okay, thank you very much for your introduction. I hope you can see my slides. As Scott just said, my name is Benjamin Iffland. I'm a postdoctoral researcher at Bielefeld University. I'm working with Frank Neuner, who developed the narrative exposure therapy for several years now. And also I'm working as a clinical psychologist and a psychotherapist, especially with traumatized patients. As Scott just said, narrative exposure therapy, or NET, by Schauer and Neuner is a short-term trauma-focused treatment for patients with multiple trauma. NET is based on the principles of cognitive behavioral exposure therapy, and it was specially developed for PTSD patients living in unstable conditions, for instance, in refugee camps in Central Africa and in low-resource countries. To understand the rationale of NET, it is important to know that within the NET context, PTSD is considered a memory disorder rather than an anxiety disorder. This means that we focused mostly on the dissociation of remembering a traumatic event and the feeling as being in this situation, and it is reflected in the symptom of flashbacks within the PTSD categorization. And to understand this symptom, it is helpful to go through some basics of memory processing. Most categorizations of long-term memory structures propose the existence of two separate memory systems that run in parallel during memory functioning. On the one hand, there's the declarative memory or cold memory, which contains facts and knowledge about the world, knowledge about specific events in the context of life in time and space, and we were able to deliberately retrieve content of this cold memory, and we can report in a chronological order about the content. On the other hand, there's the non-declarative memory or hot memory, which contains sensory, emotional, and physiological perceptions. It is automatically activated by external or internal cues, and it implies the sensation of here and now as we feel it in flashbacks, and reports are fragmentary. On a neural level, the declarative memory is associated with hippocampus activity, whereas the non-declarative memory is associated with amygdala activity. And when it comes to memory functioning and traumatic stress, it becomes very interesting because we know that the two structures which are important for the two types of memory do have different functionality during intense traumatic stress. That is, the ability of the amygdala, as we can see here in the red line, to store the ability of the amygdala to store features of an event increases during traumatic stress. That means during a traumatic event, the memory function of the amygdala is greatened. On the other hand, the function of the hippocampus during stress is quite the other way around. The capacity of the hippocampus to store information is quite good when we have a moderate level of stress. However, when the stress increases, we have a massive decline in the performance of the hippocampal formation. That means during stress, the hippocampus is malfunctioning, and this leads to a contextual information that is badly stored. So the problem in PTSD is not so much the malfunctioning of the hippocampus, but the dissociation between the different memory systems. Highly functioning amygdala with good fear conditioning and a malfunctioning hippocampus with loss of context formation. And this leads to traumatic memories being characterized by sensory perceptual representations, which are stored in so-called implicit fear networks, which can be automatically activated by different internal and external cues. In addition, these traumatic memories lack context. So the traumatic event is isolated in the life history of the patient. Within the memory of a traumatic event, time stands still and spaces and places are restricted. This leads to twofold difficulties in recalling traumatic memories. On the one hand, avoidance due to fear of activating the fear network, because it implies the frightening and painful recollection and reliving of the event. And on the other hand, difficulties in putting memories in the context of the event and in the chronological order of the patient's lifeline. And from this, we draw different implications for the treatment of PTSD. Addressing two important mechanisms. At first, the activation of the fear network to enable habituation. And second, we want to complete the autobiographic memory. So we want to contextualize the associative memory to inhibit the threat structure. Simply put, we want to put together the hot and the cold memory and contrast remembering back then and the feeling of here and now. And as a consequence, in NET, we do not just focus on one or some important traumatic events like in prolonged exposure and in other treatments, but we focus on all important traumatic and pleasant events in chronological order. So traumatic events are never regarded isolated in life history and never isolated in the trauma context. And in doing this, NET or NET consists of different components. After a thorough diagnostic and psychoeducation, we reconstruct in a chronological order all important life events in a so-called lifeline. After that, we expose the patients to the hot memory or the implicit memory and activate the fear network. And then we try to integrate these hot and cold memories into one big memory network and try to enable also the cognitive re-evaluation of the life events as a result of this new and repeated processing. Lastly, going through and writing down the narration gives dignity to the patients and gives a statement for the patient and also others. And it can also serve as a testimony to fight against human rights violations. So in the following, I would like to present some detailed overview over the different components of the NET. In the first NET session, we always start with the so-called lifeline. That means that we recollect all negative and positive life events. In doing this, the timeline or lifetime of the patients is represented by a chord, a row, and then we start at the beginning, at the birth of the patients, and every negative life event is represented by a stone or stick, and every positive life event is represented by a flower. And then we go through the whole life from the beginning, the birth, to the present. This lifeline gives at first an overview for the patient about the chronology of life, and also it gives an overview and also control over the treatment and what to expect from the treatment, because they know what kind of and what life events will be focused in the treatment. Also, it is visually attractive to do and to go through different biographies. For the therapist, it's also a route map for the treatment process, because we also know what to expect it in which section and which session. So it helps us to structure the treatment sessions. And as a example, I want to present the lifeline of Richard, who was an 18-year-old patient, a former child soldier from Uganda, who has been abducted by the Lord Resistance Army and later was forced to kill his sister. And as you can see here, we start with flowers representing the birth, followed by several stones, which are named with different headings, so that we know what happened at this time point. And with the green numbers, you can see the green numbers indicate the different sessions of the treatment when the therapist planned to focus on the different life events. Then in the second session, we start with the narration in past tense. Past tense because it's a memory. It's we want to show and also give the impression that all the life events that were that are gone through happened, and they're not happening right now. So we start in past tense, and we start with the life circumstances when the patients were born, if they have siblings, if they had friends, if the games were, what kind of games were played. Usually we start with, if possible, positive life events to practice and to get familiar with the process and questions during the narrations. And as an example, I want to represent and present you the narration of Richard. I was born in 1987 at Ubia Highland, close to Gulu. I was the firstborn child to my mother and my father. After me, there was a sister called Agnes, a brother called George, and Stephen. My mom was about 23 years old when I was born. She was such a good mom. She loved me very much. She was tall, big, and strong. Whenever she went to the market, she brought nice things such as shoes and bread and clothes. Once, when I was 4 years old, she brought black closed shoes for me. I was so happy and proud. My mom also told beautiful stories and rhymes. So we start the narration in the very first beginning of his life. And then in the next sessions, the typical structure looks as follows. We reread the narrative of the last sessions. We give the patient the possibility to build on changes and to add some details. And then we continue the narration. Usually one session lasts 90 to 120 minutes. And it is very important to realize whenever you approach a stone, because then we have to slow down and then we have to recollect all important information about the stones. So talking about the stones is the next slides. I will present you how to deal with these stones. At first, as I just said, you have to recognize that you're approaching a stone. Usually patients get hesitant or maybe impatient and get faster in the narration, and we have to recognize this. And then we shall slow down and try to get a clear picture about the situation before the stone happens. So we have to get the context of this event. And then we connect hot and cold memory. As a rule of thumb, I try to imagine the whole scenery like a little movie, because as soon as I have a clear picture of this scenery, the narration is detailed enough to go on further. And to connect hot and cold memory, of course, it's important to ask questions about cognitions, emotions, physiological responses, sensory perceptions, but also cold contents, cold memory, so that we ask when the incident took place, where did the incident took place, who was there, who else, what else was important in this situation, and then we try to get more and more information about the event, what happened, what were the circumstances at the beginning of the incident, and so on. And to give an impression of how this could end, I also want to read the narration of Richard. It was some weeks after we have been attacked by the Ugandan People's Defense Force. That day we were walking. My sister had shoes to wear, but B, the commander, told her to take the shoes off. He said, "Now walk bare feet." I hated this man. My sister was brave. She kept walking, but after some hours, she started crying. B said, "We will kill you if you do not continue walking and stop crying." My throat tightened, my chest felt heavy, and tears were running down my face now when I heard this. I felt so helpless. I was a small boy, and I could do nothing. And as you can see, we have different aspects of hot memory combined with different aspects of the cold memory, the timing, and also the cognition, the emotions. And the last sentence is also very important and helpful for the cognitive re-evaluation of the event, to know and to say out loud that he was a small boy and he could do nothing about the situations. While asking all these questions, of course, you have to stay connected to reality. So we have to keep comparing then and now by asking, what do you feel right now? What do you feel in your body? How is your heartbeat? Is the heartbeat the same as it has been in the situation when you have been traumatized, and so on? And then we stay in this hotspot until we realize at least some relief in the patient in terms of a habituation. And until we get this, we verbalize behavior, emotions, body reactions, and thoughts. And for some patients, it's helpful and supportive to use creative tools, for example, drawings, or maybe toys to show the whole scenery. And then we repeat all this until habituation takes place. And then we close the session when reaching a safe point after the narration of the stone. So we never close the session before reaching this safe point. And then we ask, when was it over? Where were you then? What did you do? How did you feel? And most importantly, we also ask, how are you feeling right now in the situation while you are remembering this? For Richard, this safe point was as follows. The group was moving again, but I could not realize things. Then it got dark. I sat under a tree next to a mountain. There was food, but I could not eat. I also could not sleep. I was thinking and thinking. I cried. In the morning, we moved again. I could not get out of my confused state for almost 1 week, but then things got better. And then after going through this situation, we repeat this process for every single event until we reach presence. And then in the last session, we let the client choose flowers and hopes and aims and wishes for the future. So to show the patient that life is not over right now in the therapy setting, but from this time point on, it can be a better life. There can be different aspects that can be seen and taken for the patients. And then optionally, we reread the whole narrative, but usually we just hand the narrative over and sign it together as a testimony for their life history. So after having presented the process in NET, I will also present some evidence. In different studies, beyond addressing PTSD outcomes, NET showed positive effects on other psychological symptoms, such as depression, functioning, and also physical health. NET causes a significant reduction of PTSD even in unsafe living conditions, as we've shown for the refugee camps. Most importantly, there's no indication that NET can cause serious side effects or harm. NET has a comparably low rate of dropouts, also when compared to other treatments, and it has been superior to supportive counseling, short IPT, and anxiety management, CBT. And what is also very useful to know, NET has been adapted for and is effective with children, adolescents, young adults, and also elder participants. So for almost everybody who I can think of. So for every age range, it is suited. And addressing the topic of today's webinar, NET has also shown positive effects and feasibility when it was delivered by trained lay therapists. In most cases, these lay counselors were trained teachers, community members, health workers, and so on. And there are different ways to disseminate NET, and it can also be used and disseminated by using the trainer approach. So it can be easily disseminated also in low and middle income countries. As I just said, it is suited for undersupplied mental health structures in LMICs, as well as in well-developed mental health systems in high-income countries. It is APA endorsed as treatment of choice for traumatized refugees, and it has shown effectiveness in different settings, and it has been proved in several reviews. So to conclude, narrative exposure therapy is an evidence-based treatment, especially for multiple trauma. It was developed for LMICs, but also is also suitable for high-income countries. It is suited for adults and children. It reduces PTSD, but also other psychological symptoms. It gives trauma context. It is culturally sensitive. It is easy to disseminate. And last but not least, it is appealing and understandable for therapists and patients. Thank you very much. And I'm happy to reply to your questions.
Thank you so much for that. That was really helpful. I have to say, someone who's been made aware of this as a form of treatment, it was really great to be able to see you kind of walk through exactly from step to step. And I think we got a lot of good feedback about you doing that. So thank you. So question, where do I start? You mentioned rereading the narrative at the beginning of the sessions. Is that narrative recorded and transcribed, or is it the whole thing written down initially?
It is the whole thing written down. Usually we work with some helpers who write it down, but you can also do it yourself as a therapist, because usually when you have gone through the whole narrative or the narration of one traumatic event, you know the whole story also 2 or 3 hours later, and then you can write it all down. And then we write it down, and then we reread it in the next session.
Excellent, thank you. You mentioned that it's most popularly used in group scenarios. Is it usually only used as a group? Is there a reason to keep it? Okay, thank you.
No, actually, it's not that often used as a group therapy. It is a therapy used in the single and in the one patient setting, but it can be disseminated very easily in group settings. And of course, like the psychoeducation part can be also applied in group settings. But the therapy itself is not as a group therapy.
Got it. Thank you. So it seems like you're dedicating a session or more to kind of building the rope with the flowers and stones, and after that you begin exploring each point. Is that correct?
Yeah. At first, like, we get this overview in this lifeline, and then we go through every single event.
Excellent. Is there any concern around re-traumatizing a person when hearing or making them go through a stone event? And in that case, what do you do if it becomes problematic?
Well, actually, the people come to us because they are suffering from their PTSD symptoms. So there's no sense of re-victimizing them or re-traumatizing because they are already have the full PTSD symptomology. So this is not the case, and this is not a problem.
Excellent. What signs, clues, or signals do you look for to sense that a client is feeling some sense of relief when a hotspot?
Well, usually the way they remember it, like for instance, I can see that the arousal of the patient is going down. I can hear the way he talks or she talks is getting a bit more relieved. So from this signs and from watching the patient, I can feel and I can see that there's more and more relief in remembering and telling the story. So we go back and forth within the story, and after a time, it's much easier for the patient to go back and forth and to remember different aspects and to talk about different aspects. And so it's more like it's a combination of the way they talk, the way they behave, the way they physically react to the whole story. And then when this all goes down in terms of habituation, then we can go on further.
Thank you.
And it's a very, in this, we are very close to our patients. It's a very, like me as a therapist, I'm very active and I'm also very direct. I'm very close to the patient, and I try to be very, very empathic to also feel what the patient feels. And then with this, I really can tense the habituation.
Excellent. What would you say the average number of sessions is that would be required to have someone successfully go through NET?
Well, actually, it depends on the amount of traumatic events, but usually it goes up to 14 sessions.
Thank you.
12 to 14.
Does the size of the stones have significance in the narrative?
It can have a significance. So it's up to the patients whether they want to choose different sizes of flowers or stones while taking while telling their lifeline. It's up to the patients. We just hand them stones and different flowers over, and usually they get an impression, well, this is a big stone, this is like a stone which is smaller, which is feels a bit better than the other one. And also the flowers have different colors, the flowers have different sizes, and of course every patient gives a different meaning to the different stones and flowers.
Very good. A couple of people asked this. How much do you explain about the process before you begin with each patient?
We fully explain and describe the process, and we also explain that it's not easy to go through this process, because we also tell them about side effects in terms of course, when you go through different traumatic events afterwards, you will not sleep very well. And afterwards, of course, you will think a bit more about these situations, and not just a bit more. You will think way more about these situations. And these are side effects, but we want to have these side effects because these are some way this is how the whole story functions, because the whole memory system can re-evaluate and restore the whole system in the memory systems. So we want these side effects, and of course we tell this patients before that this therapeutic process is very harmful for them. But there's no other way. We cannot just avoid all this. Well, we have to go through it.
Very good. How would we know, or as providers, when to explore the use of NET versus other forms of therapy? Are there particular things that you're looking for?
Well, usually, if there's just one traumatic event or some single trauma, then there's no need, so to say, for the NET. Then you can also use other exposure therapies. But as soon as you have multiple trauma histories, then it's useful to use NET, because later traumatic events and the processing of later traumatic events, it's much better understandable if you have already understood the early traumatic events and how they were processed. So as soon as you have multiple trauma, then NET is definitely the treatment of choice.
Excellent. As part of this process, are you providing any coping skills for when you're bringing, some things are starting to come up, and over the course of these sessions, are there any coping skills provided in terms of helping people manage what they're going through once they leave the sessions before they come back for the next one?
Well, actually, at first we make clear that people are in a stable situation, so there we ensure physical safety, and every time before they leave the therapy room, I make sure what they do within the next hours. So we don't have these sessions in the afternoon or a late afternoon, because of course it's hard to cope with all the content when it's 7 p.m. and you don't have nothing to do for the rest of the evening. So there are different coping mechanisms and different ways we try to help them to go on the next hours and the next days until the next session.
Excellent, thank you. I've got two more questions. Number one, people are asking about, how do you get typically, is there a training process? Is there certifications, or how does it work on the provider end?
So how to learn the NET? Yes. Well, there are different courses. Well, actually, most courses are given here in Germany, but also there are some providers in the US. And if you're interested, you can write me an email, and I will try to find out where there are some providers for this training. But usually it's not difficult to learn it as soon as you have understood the mechanism and how to ask all these questions. So that's why it's so easy to disseminate, and why it is perfect also for the lay and context, and also for LMICs, because it's not so difficult to learn as soon as you have understood the rationale.
One last question for you, and then I'll let you go. How do you usually take care of yourself after an intense session?
Well, of course, there's supervision and intervision with other therapists, with colleagues. And also, I don't have too many patients at a time. So I, as maximum, have 3 trauma patients at the same time, because of course it's overwhelming at some points. And usually I do some sports afterwards to also have some psychohygiene for me. And also I'm talking with a lot of colleagues about the different situations.
Excellent. All right, Dr. Iffland, thank you so much for your time and your flexibility today.